Hello student, now we're going to be talking about pain management. Pain management, next slide. So pain is a private experience, right? It's a private experience. It's an unpleasant sensation, usually associated with disease or injury. One person's report of severe pain may seem like almost nothing compared to the other. Pain is generally common, especially at the end of life, because of arthritis, circulatory disorder, immobility, neuropathic, cancer, and other changes, especially with the elderly client. Everyone's experience pain, again, differently. Especially the older people, they respond to pain differently as well. The sources of pain can be many different things, right? Nociceptive or neuropathic type of pain, as I just discussed. There are some misconceptions of pain. For example, the caregiver is the best judge of pain. People with pain will always have obvious signs, such as moaning, abnormal vital signs, or not eating. Pain is considered a normal part of aging. These are all misconceptions I'm reading out to you. Addiction is common when opiate medication are prescribed. Morphine and other stronger pain relief should be reserved for the late stage. Morphine and other opiates can easily cause lethal respiratory overdose. All misconception. Anxiety always makes the pain worse. So it's misconception. So you need to really remember this when you're caring for your client about this, and try to make sure that you understand, because it is a subjective assessment of pain. There are some consequences if pain is not addressed. There are some consequences. So sometimes the patient will have poor appetite. There's disturbed sleep. They would withdraw from social activity and talking. They will be sad. They will be anxious. They will be depressed. They may have physical or verbal aggression. They may wander. They may have difficulty with transferring and walking. So therefore, they'll just stay in bed, which leads to other complications. Right? It can lead to bed sores, incontinence, increased use of other chemical restraint for the healthcare practitioner, right? Decreased ability to perform their ADLs, because remember, we want to promote immunity. It would impair their immune system. So when someone comes in with a pain, it's important for us to get a history of that pain. So you want to find out about the onset, right? When did it start? The intensity. From the, give them to scale it, is it from 0 to 10? The duration, how long does it last? All right. And then you could find out, is this an acute pain or is it a chronic pain? Right. So there's a difference between acute pain, because, the discussion of pain can be categorized by the duration of it, right? So an acute pain is usually very brief, goes away with healing generally, and usually lasts less than 6 months. It's not necessarily more severe than chronic, but it may be sudden onset or slow onset. Examples of what we call like acute pain will be from like a broken bone, strep throat, and pain after surgery or injury. The chronic pain, usually it's expected to have an end with cure or even with death. But usually aggressive pain is used and addiction is not a concern, right? So this is cancer pain. But then you can have chronic non-malignant pain also, right? And usually the pain has no predictable ending, right? It's difficult to find the specific cause usually. Often cannot be cured. For example, if someone's having osteoarthritis and it's always painful, that's going to be there until, maybe surgery is done. Next slide. So nociceptive pain, this is noxious stimuli that are transmitted from the point of cellular injury over a peripheral sensory nerve to a pathway between the spinal cord and the thalamus, and from the thalamus to the cerebral cortex of the brain. It comes in different forms. So pain can be categorized by the type of pain. So the types of nociceptive pain are somatic and visceral. Somatic pain is usually pain that occurs from internal organs, right? An example of that would be like tumor growth, gastritis, chest pain. And usually when they describe it, it's described as not localized, or refers to other places, like, to the left side, constant and dull, right? And it usually does not affect the movement per se. The pain itself does not affect the movement. For treatment for this type of pain, usually they need stronger pain medicine, right? And then you have visceral type of pain. Let's go to the next slide. So just a review of what I just said, this somatic pain, again, mechanical, chemical, thermal, or electrical burn can also affect that. It's usually superficial, you could have it from an insect bite to paper cut, right? An example, again, I spoke about, but arthritis is also one. Next slide. The visceral pain, that again arises from internal organs such as the heart, kidney, or intestine. Ischemia, compression of organs, and it's usually diffuse and poorly localized, right? Refer pain, which is, something that you should know the terminology, is discomfort in a general area of the body, but not in the exact site where the pain is located. So for example, someone is complaining of pancreatitis pain, usually it radiates to the back, right? So that's pancreatic. So refer is you expect it to be on one side, but it radiates to the back. Next slide. Neuropathic pain, the pain that processes abnormally from nerve cell. So usually it's the nerves are the issue here. It results from damage to either the pain pathway in peripheral nerves as pain process center in the brain. Right? Example of this are, like diabetic neuropathy, right? Diabetic neuropathy, complication of diabetes, the phantom limb pain, and spinal cord injury, stroke, herpes zoster, this kind of stuff. And usually people describe it as burning, stabbing, feel like pins and needles, shock-like and shooting pain. That's how they describe it, right? It's important to learn how to describe, the pain, because it makes a difference for a lot of people. And in terms of treatment, radiation, we can use drugs such as opioids and tricyclic antidepressant to treat it, like Neurontin, for example. Next slide. So the difference again, acute versus chronic, we've talked about that. So acute pain would last less than 6 months, associated with tissue trauma. Again, it's usually as the injury heals, the pain goes away. Manifestation that they have an acute pain, you usually see a change in the vital signs, the blood pressure, and heart rate and pulse. They may be diaphoretic and their pupils will be dilated, versus the chronic pain, which lasts longer. It does definitely affect the quality of life, because if you're always in pain, it's going to affect your ability to perform your activity of daily living. And manifestations are very similar, but you can see depression, in the sense that they're constantly in pain. It affects them, so they are depressed, they are helpless, they may lose weight, fatigue, and maybe some physical immobility You don't generally see like those changes in vital signs, you know, but it does significantly impact someone's, you know, life. Next slide. All right, so chronic pain is described, this is a question, chronic pain is described as an unpleasant sensory and emotional experience associated with what? Is it actual tissue damage, or is it actual potential tissue damage, and so forth? So the answer you think is B, actual or potential tissue damage. Next slide. This slide gives you the rationale for that. The rationale is chronic pain is associated with actual or potential tissue damage. Chronic pain is associated with many behaviors that people do not normally associate with pain. There is no change in vital signs with chronic pain. Remember that? Next slide. So now we're going to talk about pain transmission. So the transmission of pain takes place in 4 phases as outlined in your textbook. That is figure 11-3. And these phases include transduction, transmission, perception, and modulation. Transduction is the conversion of the chemical information in the cellular environment. So you see a fire, your finger comes in touch with a fire, right? That moves towards the spinal cord. You see that on the diagram, right? This phase is initiated by the cellular disruption, during which the affected cells release, you know, various noxious chemical mediators, right? That's the neuropeptides. Then it travels to the second phase, which is the peripheral nerves fiber form synapses and with the neurons in the spinal cord, right? So transduction is 1, number 2, transmission, and then after that it goes to the brain, right? And that is the perception. And the perception is different from everyone, right? Refers to the phase of impulse transmission during which the brain experiences pain at a conscious level, but it happens simultaneously, right? So individuals perceive pain differently. And so you have the pain threshold, and this is the point at which the pain transmitted neurochemicals reaches the brain, causing the conscious awareness, right? Some people have a lower pain threshold, some people have a higher pain threshold. And the tolerance of pain is the amount of pain a person endures when the threshold has been reached, okay? And again, you know, it is different from each person, right? Each person has their own threshold. For me, 1 may be, you know, my pain level at 1 may be 10 for somebody else. And there's also cultural differences and ethnicity differences when it comes to pain, right? And then the last phase is the modulation phase. And this is the phase of pain impulse transmission during which the brain transmits a response drawn to the spinal nerve to the point where the pain transmission originates to alter the pain experience, right? And your book outlined the different pain theories that attempt to explain how pain is transmitted and reduced. No one theory is all encompassing, right? So there is the gate control theory, there's the pattern theory, and of course there is the endogenous opioid theory. We have our own opioids induce way to manage pain. Next slide. So as repeating the information I just talked about, it tells you the transduction is the conversion of chemical information in the cellular environment to the electrical impulses that move towards the spinal cord. Okay. Next slide. And the transmission phase, again, the peripheral nerve fibers from the synapses with the neurons in the spinal cord. So it's just how it travels. And then the next slide is the perception. Again, the brain experiences the pain at a conscious level. It locates the pain, its intensity, and what it means, and gives emotional response to this pain, right? And I talked about the pain threshold, the point at which the pain transmitted neurochemicals reach the brain, causing us to be aware of it. So at this point, we have a lot of pain. And of course, it varies, like I said, by age and gender, you know, and culture, right? And also, if you're tired, you may not be able to respond to the pain as someone who's not tired. Next slide talks about the modulation phase, and again, this is where we have our natural, ability to control the pain. So painful sensation is reduced in this phase. Next slide. Your textbook on page 129 outline, assessment of pain. There's no perfect way to determine if pain exists, right? However, that we as nurses, we need to be able to identify and make sure we collect certain information about the patient's pain. Pain is considered a vital sign, right? So you want to ask for the onset, the quality, and the intensity of pain, the location of the pain, and the duration. And you want to say, was there any treatment that was tried, and what makes it better or what makes it worse. You also need to make sure that you find out any things that make the pain gets worse, or better. Look at the nonverbal cues that support, pain, such as, clenching their jaw, frowning, crying, rocking, and fidgeting, or if they've lost interest in things that they liked before. Emotional irritability, impaired thinking, confusion, and combative, or reducing social interaction. All that will tell you about pain. So onset, again, so when you are trying to do a basic assessment of pain, you want to look at the onset, quality, intensity, location, and duration. So, for example, when did it start? Well, it started after I ate. What's the quality? So tell me about it. Is it, throbbing? Is it crushing? Is it annoying? What's the intensity, right? What's the magnitude of it? From 0 to 10, 10 meaning the worst, how would you rate it? The location, the anatomical site, so it's really important. If they said is I'm having chest pain, I'm having abdominal pain, I'm having jaw pain. And the duration, the time span of is it continuous? Is it intermittent? Is it hours, weeks, or months? So it's really important to assess that. Next slide. So now here you're trying to assess the intensity of the pain. So there's many different ways you could do so. No reliable indicator, but there's many different things that we have used. We have the Baker face scale, so the face is asking, you're showing the different face, and then the patient can tell you which one. And it's usually universal because people can point to what it is, and individuals who speak a different language, the children can use that scale, right? And of course the numeric scale from 0 to 10, 10 meaning the worst type of pain. How would you rate your pain? And of course the word ones, so no pain, mild pain, moderate pain, severe pain, very severe pain, and worst pain. In order for you to ask these words, this person needs to be able to speak the language. So you got to be very careful of this kind of scale. And then of course you have the visual analog scale, and you have the pediatric pain scale as well, because kids, it's kind of hard for you to assess their pain level, right? So you want to use the best scale for them, and usually the face would help with that as well. Okay, and usually children as young as 3 years of age can use the face scale. All right, next slide. Accredited healthcare facility, the right to assessment and pain management, it's a big deal. So now that's part of the requirement of facility, that they need to really assess everyone for pain as part of the 5th vital sign. Assessment is appropriate for age. They have to make sure that they're using the right tool, like we just talked about, and they've considered the developmental level, the cognitive level, the condition, and also the patient's culture. We have to assess it regularly as we do other vital signs. Healthcare workers, as part of our responsibility, we must know how to assess pain and how to treat the pain or manage the pain. And also ensuring that this accreditation also ensure that that the client's choice of pain management are respected. So the accredited bodies really try to advocate for the client. Right, next slide. So pain management, pain management, there's different ways to manage pain. We can use drugs and we can use non-drug intervention. So technique for pain management that could be used are blocking the brain perception, because if you're not perceiving that it's painful, then you're not going to be you're not going to feel the pain, right? They have things to interrupt the pain, transmitting chemicals, that those 4 phases, they can intervene with that. We can give some analgesics or substituting sensory stimuli or altering the pain transmission process. All right, your book on table, let's see, is this a table? Yes, table 11-1 talks about the different types of drugs that could be used to help assess pain level. So pain medicine can be given different routes. You can give them orally, rectally, transdermal, or parental routes, right? And you can even make it a continuous infusion installed maybe through the spinal canal, or it could be self-administered, referred to patient PCA. Usually when there is the World Health Organization, has encouraged or has like a pain ladder, right? So how to give your pain medicine. We start with, non-pharmacological treatment, if the pain persists, then you move up to other drugs, so mild opioids to moderate, and then if that does not work, then you can give opioids and severe pain, and then you can also add certain things to potentiate the pain medicine, such as Phenergan. Okay. So the drug therapy table, the analgesic drug therapy, gives you really good layout of things that you need to worry about: the common generic and brand names, the intended use, the common side effect, and the safety warnings for nurses. For example, I'm going to talk about a few of them. So opioids, so it talks about where it derives from. So there's different types of it. There's morphine, there's oxycodone, there's fentanyl, right? So what is it intended for? It's usually intended used for moderate to severe pain, and it's usually for acute pain only, right? Not for like chronic pain, right? Common side effects. So when you give this drug, you have to be concerned about what is it that is happening here. The patient will be sedated, the patient may be hypotensive, they may have urinary retention and constipation, right? Constipation tolerance is not developed, right? Constipation is a big deal when you're given these opioids, right? So we got to keep that in mind and giving the patient fluid and so forth. The warning signs for us, because it sedate your respiratory system drive, so we watch for respiratory depression and treat the constipation early with laxative and fiber, and use transdermal patch only when the pain is not reduced by other routes, right? Also you need to make sure that you understand and know the narcotic, the antidote for these opioids, and that's Narcan, and then you have the steroids, non-steroidal anti-inflammatory drugs. Those are very commonly used drugs, especially for the arthritis. So the examples of that is ibuprofen, indocin, methicillin, naproxen. You yourself might have taken some of these drugs before. It is used for mild to moderate pain, right? It's also antipyretic and anti-inflammatory, and dysmenorrhea, right? So if you're having bad menses, this is also the drug that you can use. Great stuff, but it has some common, side effect: nausea, dyspepsia, constipation. And some of the warning signs is risk for cardiovascular thrombosis, right? MI and stroke. Okay, should not be used post-operative cardiac surgery. All right, and then you have Tylenol. It's also another one that's used for mild pain and antipyretic. It's rare to see, but you see itching. Liver toxicity is a big deal, with dose over 350 to 4,000 milligrams per day. So you got to teach your patient about not taking a lot of Tylenol because of the liver toxicity. It's usually using cold and cough remedies, and easy to go over daily. So look at this table, and you can definitely see the differences. And then also on the other side of the table, continuation, there are other drugs that are used for pains, especially for the neuropathic pain. So like antidepressant, tricyclic and so forth. So look at the warning sign: suicide ideation is really big for that. So when you're studying, those are the things you pay attention on. This little box is really, really helpful. In your one of the boxes that talks about gerontological consideration, you should see that it's referring that pain is the number one complaint of older adults who take analgesic every day. Some older adults skip the dose or split the dose to prescribe to reduce their expense. A reduced dose of analgesics, especially opioids, may be prescribed for the older adult initially because they are more prone to, toxicity, right? Their kidneys are not as functioning as well as they do, and they're at risk for fall and sedation. And then constipation is a big side effect with these guys. So a bowel regimen to prevent the constipation is really, really important. Next slide. All right, so this is a question. To evaluate adequately the effect of pain control regimen, the nurse should do what? You should use a pain assessment scale. All right, pain assessment tool. So that's C. Next slide. All right, so yes, this slide is talking about the answer and the rationale. So an effective pain treatment requires a thorough pain assessment. Next slide. All right, so we just talked about this slide. We talked about the different drugs that are used to prevent or reduce or alleviate pain. We talked about opioids. We talked about the examples already. We talked about Tylenol. So next slide. Refer to your textbook too. All right, and we talked about the route that are used. Patient control analgesia, that is the patient administering their own. It has its own advantages because the patient is able to control to be part of their treatment. The patient is able to give themselves additional boluses. It prevents frequent injections. And you can also put the pain in the spinal canal or epidural. So when you do the spinal anesthesia, you need to worry about headaches, so the patient is going to lay flat. I've talked about the oral, rectal, suppositories given in transdermal. We also talk about that just briefly. Next slide. So we are also addiction, again, repetitive pattern of drug seeking and drug use to satisfy a craving for the drug. It's mind-altering or mood-altering effect, right? Fewer than 1% of clients who need drugs for pain relief become addicted, right? Because this point is important because we want to make sure that people take the pain medicine when they need the pain medicine, not to worry about addiction. Okay. Next slide. And tolerance is the condition in which the patient needs an increase in dose, of a drug to achieve the same effect when the drug was first administered, right? The consequence of pain control. So an ineffective dose should be increased by 25 to 50%, right? But we as nurses do not do that. We have to consult with the physician. We have to remember that when we are wasting narcotics, there's other nurses that are involved. This is one of the checks, right? Because there's a lot of abuse of drugs within even the nursing profession. Next slide. Physical dependency, the person experience physical discomfort, and this is seen as the withdrawal symptoms, DTs, right? When, the drug is not taken, as it should or stopped abruptly. So to avoid withdrawal symptoms, the drugs should be discontinued gradually over a week or longer. Next slide. So a client taking opioids for cancer pain begins to require more medication to provide the same amount of anesthesia. This is known as what? This is known as drug tolerance, right? Next slide. So drug tolerance is the need for an increased opioid dose to maintain the same effect. Right? Next slide. alternative non-drug therapy. These are really good. Your book really outlined what they are too. But the transcutaneous electrical nerve stimulations, these are great, especially for someone who has like what you call it, like, injury in a car accident. It helps, kind of relax the muscle, therefore relieving pain. Right? Acupuncture and acupressure. Acupuncture is using small needles and putting them in different points, where the pressure is, to help relieve pain and stress. Pressure is pressing certain points, and of course, not everybody can just start doing the right thing. There are individuals that are trained, to do so. Cold and heat therapy, it's really good. They're well established techniques for relieving pain. Again, usually after self-injury, 24 to 24 hours, you apply cold, and then after that you apply the heat. The nurse cannot apply heat without a doctor's order. Okay. Spinal surgery, cordotomy can be used, for to help relieve pain. So with cordotomy, what is happening is interruption of the pain pathway, in the spinal cord. It's a little bit extreme, but these are ways for clients who has chronic pain, and it's debilitating. Chronic pain causes depression. It impacts the quality of life, and it's once all the other treatment have failed, steroids cannot be used anymore, because steroids can be used to help with inflammation and pain. But once all of that stuff cannot work, then surgery is usually the best option for a lot of these people. Other ways to help with pain management is distraction, relaxation, and imagery. These are, you can distract with the activities, you can distract with a movie, this kind of stuff. All right. Next slide. So our job as nursing management is to perform a comprehensive assessment of each client's pain, because each pain is unique, and determine again the onset, quality, intensity, location, and duration of pain, and administer of analgesia every 3 hours rather than the PRN often provides a uniform level of pain relief. And of course, we need collaboration with clients to give them the pain medicine. They have to be part of that option. They may not want drugs, they may just want other non-drug therapy. And then of course, assessing the complication related to pain and other prolonged use of medication. So sedation, respiratory depression, risk for falls, knowledge deficit, and constipation. And so making sure that those possible complications are alleviated. The page that I referred to you with the drugs has really outlined all the complication or the nurse safety issue that you should be paying attention to. Next slide. So there are some nursing diagnoses for pain. Well, you have acute pain or chronic pain, right? So acute pain, what's an expected outcome? So the client will rate the pain intensity at a tolerance level of 5 within 30 minutes of pain medication technique. So that's good. So what are the interventions for that diagnosis? Well, assess the pain level and characteristic at least every 2 hours while the patient is awake. So if they're asleep, you're going to leave them sleeping, right? Because when pain is bad, people don't sleep. Modify or eliminate the factors that contribute to pain, and administer prescription analgesics or alternative pain management technique promptly. That ends this slide.